Good evening, all of you. I am not oriented with this entire batch because I was part of the Sanger, and so I don't know who's sitting in the audience. So maybe some things will sound silly to you, not of relevance, but I'll try to make it relevant to the last person in the row. Okay, fair enough. I thought I was just speaking to the most intelligent people in the crowd, so nobody will be interested. Thank you, sir. So my first case is a 77-year-old male patient who presented with cytopenias. And in the middle of the study, before I start, I have my colleague, Dr. Avinash Gupta, sitting in the audience. He is as good as I am, and he's my better half professionally. So if there is any mistake, please correct me on the way. 77-year-old male patients with cytopenias and hepatosplenomegaly. Bone marrow study was done. Sample was sent for flow cytometry, cytogenetics, and NGS studies, which is the protocol, Tata protocol. You can see there are graphs which left shift with shift cells in the background, and the MTO is positive in the blast. Now, on morphology and flow cytometry, it came out to be AML with maturation. Cytogenetics was normal. We did a fragment analysis. Our protocol is to do NGS in all cases and Sanger capillary fragment analysis for SEPA, FLIP3 ITD, and NPM in all the AML cases. So the fragment analysis was done, which showed a positive mutant band, which was 54 base pairs size, and allele ratio is 0.67. Why I have marked it in red is, as far as the new guidelines are concerned, allele ratio is obsolete, but still we continue to do it. Allele ratio, how it is calculated, is not a part of this discussion. And again, NPM was positive because we had a normal band at 169 base pair, and mutant band because of 4 base pair insertion at 173 base pair. Now, you would say that if we are planning to do NGS in all our patients, then why should we at all do a Sanger in these patients? So FLIP3, this is the paper from which I have taken the reference. We are just following the 2022 ELN guidelines, which says that FLIP3 mutational screening should include the analysis of internal ITD and KDM mutations, because the longer FLIP3 ITDs may be missed by next generation sequencing. Therefore, we recommend continuing to use capillary electrophoresis. So ideally, one should use both the modalities because FLIP3 ITD is an important prognostic marker. Now, in our lab, what we have standardized is a 70-gene custom NGS panel, and we're working on Illumina mini-seq platform. I will not discuss because I know by now you have become learned scholars in NGS. So basically, when it comes to from the machine, it is in the FASTQ form, converted to BAM or SAM file, then ultimately to the VCF file. And we use the Illumina variant interpreter software for the for getting an Excel file. Then we apply certain filters. The filters are basically the exonic mutations are chosen, which are non-synonymous, comprising of the in-frame and frame shift insertions, deletions, and missense mutations and nonsense mutations. Population frequency of at least less than 0.01% is not selected. Apart from that, there are many other filters, but these are the most important ones. And then we go back and see. We've tried to see the clinical significance of each of these mutations using from these many tools that are available online. And we annotate, we validate these variants, whatever we have got, and sort them using variant validator. So this is how we work in our lab. In a nutshell. So coming back to this case, in this case, we had a FLIP3 ITD positive, but here when we see the NGS, there is no FLIP3 ITD. So this is one of those cases where if we had not done a Sanger, we would have missed. So what we got IDH2 mutation, which was a missense variant, common one, arginine 142 glycine, which is the commonest. And IDH2 is important because we have IDH2 inhibitors, which we can use in relapsed refractory cases of AML. So this is a significant mutation. Then we got a type A NPM1 mutation, which showed a PCTG insertion. We saw that in Sanger also. And then we got an SRSF2 mutation, which was SRSF2 mutation, which was an in-frame deletion. The graphs are written in the extreme right column. Then ultimately, this becomes a case of AML with NPM1, FLIP3 ITD positive, and SRSF2 positive. So where will you classify this case and how will you risk stratify this case? It's very simple. When we are sitting in a lab reporting, your report should be that which is clinically relevant. You may report hundreds of mutations, and if it doesn't mean anything to the clinician, it is a cross. So the clinician should draw out something significant from your report. So first thing is, where are you going to classify it? And the second thing is, how are you going to risk stratify this case? So let's see, we'll go back to this. This is our Gita, Bible, and Quran. Who are dealing with hematological malignancies. This tradition has come, and here the AML with defining genetic abnormalities have been specified. So AML with NPM mutation is a defining genetic abnormality. And ELN recommendations also give a hierarchical classification of the international consensus classification of AML, where we say that AML is even defining recurrent genetic abnormality is present, then that's a priority. It means our case is NPM mutated, so we'll define or we'll classify our case as AML with NPM mutation. So the classification is sorted. If there is no defining recurrent genetic abnormality, then we give preference to the TP53 mutation. Where is the cursor? I don't know, I can't see it. Okay, and if TP53 is negative, then the MHC related mutations are given privilege related cytogenetic abnormalities. So this is how you have to classify your case in terms of hierarchy. So in this case, we know we are dealing with the case of AML with NPM1 mutation. This patient was started on palliative azacitidine. 2 cycles have been received. The last follow-up PBC was normal. MRD sample has not been received yet. Now, after the, there are 3 things you have to keep in mind. The WHO has, new WHO has come. There is an ICC guideline. There is 2022 ELN guideline. So these 3 have to be in a hematopathologist's room at all times, because there is a lot of conflict and trying to come to consensus. So other than this, then our case is here, mutated NPM with FLT3. So what does this entity in the intermediate category, what is the instructions according to the ELN? ELN says that for the time being, these markers, the mutated SF7, B4, EZH2, RUNS1, SF3, V1, FRSF2, STAT2, U2, F1, and ZRFR2. In our case, what we have one FRSF2. So these mutations should not be used as an adverse prognostic marker if they co-occur with favorable risk AML subtypes. So if these are present in this group, then they will not affect the risk stratification. But ours is the intermediate group, so probably our team will shift to the adverse category. Is it clear? हाँ तो बोलो. नहीं तो very इतना बुरा है सर. Thank you. Okay, so now you have understood why should we do NGS in NPM1 mutated cases, because obviously it will not help in the classification, but it will definitely help you in prognostic risk stratification of your case according to the ELN guideline. And the field of FLT3-ITD not enough, maybe say because one you can look at these mutations there. So we have some Indian data also by Dr. Nikhil Patkar, who is a genius in molecular. In this paper, he has showed us something about the NPM scoring, where the presence of type A NPM1 mutation corrected VAF less than 79%, DNMT mutations, FLT3-ITD, VAF, and IDH2 mutation. On the basis of these 5, you do a scoring, and when we scored our case, our case was scored more than 3, not a score of more than 3, which is poor genetic risk. And clearly you can see that there is a difference between the favorable and intermediate and poor risk groups according to the NPM scoring. So all of these things help us in deciding how a patient is going to behave. Even if it is a good category, he might require a bone marrow transplant, targeted therapy like IDH2 inhibitor later on, because in AML you have very few cases to play with as far as the clinician is concerned. So if the sleeping audience one has to be English is not very good, I'm a Bihari. So the truth is, if you have the same previous case and the NGS is here, the previous case, in the previous case, your NPM is negative, but cytogenetic is normal. NPM was positive in previous case, now it has become negative, and the NGS report is like this, where you have a FLT3 ITD present, positive with a 54 base pairing frame insertion and FF3B1 mutation. So how are you going to approach this case? Where will you classify and where will you risk stratify? No, NPM is negative, so that entity is out. FLT3 के basis पे you don't classify. ठीक है? So now where are you going to classify? तो चुप ही रहो यार. ठीक है? So hierarchy अगर उसमें देखने पे NPM तो है नहीं, 53 है नहीं. The next entity that you can क्या था? B1 था. तो ये केस क्या बन जाएगा? हायरार्की में यहाँ पे आ जाएगा. तो ये केस हमारा AML MLC बन जाएगा. ठीक है ना? इस केस को हम ऐसे क्लासिफाई करेंगे. क्लियर है? इस केस का जब प्रोग्नोस्टिकेशन करने लगेंगे तो फिर हम कैसे जाएंगे? सेम चीज ये यहाँ पे आ रहा है. ये FLT3 होगा. इसमें कहते हैं कि हमारे NPM जो कि हमारा केस है विद FLT3 ITD जो कि हमारा केस है विदाउट अदर जेनेटिक लीजंस हैविंग इंटरमीडिएट. हमारे साथ क्या होगा? हमारा NPM है, FLT3 ITD है, एडवर्स जेनेटिक लीजंस आ गए हैं, तो हमारा केस अपग्रेड होकर एडवर्स हो गया. ठीक है? तो ये क्लियर है. तो ये सब जानना इसलिए जरूरी है टू मेक द रिपोर्ट मोर रेलेवेंट टू द क्लिनिशियन हु इज गेटिंग द रिपोर्ट कि उसको इससे क्या रिजल्ट करना है. बहुत सारी चीजें लिख सकते हैं बट उसका कोई मतलब नहीं है. सेकंड क्वेश्चन जस्ट टू स्लीपिंग ऑडियंसेस 69 ओवरऑल मेल विद AML. इसमें TP53 म्यूटेशन आ गया है. फिश पे मोनोजोमी 5717 आ गए. आपको ये भी पता है कि साइटोजेनेटिक्स एनालिसिस डिफाइन ऑन द बेसिस ऑफ साइटोजेनेटिक एब्नॉर्मैलिटीज आल्सो. तो इसको कहां डिफाइन करोगे? हां TP53 पे रुक जाओगे ना. यस. तो ये यहाँ की म्यूटेशन आई हुई है, यहाँ टाइप में चेंज हुआ है, तो इससे पहले ही क्लासिफाई तो करना है क्योंकि इसमें TP53 मोर देन 10% मार्क आया हुआ है. ठीक है सर. टाइम एक और ले लूं. हाँ ठीक है. थैंक यू सर. Case 2, it's a 10-year-old male presenting with fever and hepatosplenomegaly. There was no lymphadenopathy or cutaneous lesions. अच्छा. Bone marrow study was done. Bone marrow में 19 का average expression आया था on 34 positive blast, which were also 56 positive, 117 positive, and 33 variable, and MPO was positive. So we know it's the case of AML with average 19 and 56. So do you want to advise something specific in this case? Yes, somebody said it. Yes, very nice. So we knew it was on this. So we did an RT-PCR for runs 1 T1 and it came out to be positive. ठीक है. And हमको जो प्रोटोकॉल है उसके हिसाब से हमने NPM FLT3 भी किया, वो नेगेटिव पे हमारे पास सिर्फ वो आई है wild-type failure sign mutant ones. So now should we do NGS in this case because it is already classification as a genetic abnormality. So it will always remain a translocation 821 ml. Why should we do an NGS in such cases? We did an NGS and let's see what happened. This case had multiple mutations involving SETBP1, ASXL1, KIT, RAS21, 2 mutations rather than ASXL1. And CKIT D816V was negative in this case. So we wrote it as AML with runs even with multiple somatic mutations, including the patient was started on 3+7 induction and post-induction AML MRD was positive. I have to explain this also, but I'm skipping this part. We cannot take ML MRD now. So, this patient was started on high-DAC consolidation regimen, after which the MRD came out to be negative. Sorry, am I going retrograde? Yes. Anything to learn from this case? So now if you go to the 22 ELM guidelines, it says that if your case concomitant KIT and FLT3 gene mutation does not alter risk stratification in case of translocation 821. Okay, so that should mean that we need not NGS whatever comes. It's not going to affect our risk prognostication. The treatment remains the same. The patient will get a 3+7 followed by either. Why should I invest money? So again, there is a literature from Indian data. Why I'm showing the Indian data is because our people have a completely different mutational profile and their behavior, genetic behavior, treatment behavior is very different from that of Western literature. So we should know how our patients are behaving so that we can treat them accordingly. So this is again by the legend himself, where this quote, the translocation 821 associated NGS mutation, and we found in this study that if the mutation burden of translocation 821 mutated AML were more than equal to 2, and if there were concomitant presence of KIT, FLT3, NRAS, FLT2 mutation, RAT21 mutation, they scored it and they found that if 2 or more mutations are basically present, it is going to have a poor genetic risk. You will fit in there, you see our case will also have a high score. So, and clearly, these patients with multiple mutations had a poor survival, overall survival as well as relapse-free survival as compared to the ones with no mutations on NGS. Now, I'm going to change this a little bit. Same kind of a patient, young age, 10-year-old male, AML with translocation 821. The NGS report is this. In the previous report also, we had a kit, but we didn't pay attention. Because it was not DA816V. Now, this again is a case of AML with translocation 821, and there were multiple mutations in kit. But again, it was not D816V. It was 822. 822. So we were just following that case. It was started traditionally as 3+7 induction. The first induction marrow was received, and the MRD is positive. A small signal is present. There was increased mast cell which expressed average CD2. There is a mast that less than 5%, and what we saw was post-induction marrow was in remission, more or less. The blasts were not increased, but they showed large clusters of mast cells in bone marrow, including atypical forms. So this case, biopsy usually is not done in our AML patients post-induction. So we could not fit it into the major criteria of bone marrow biopsy for systemic mastocytosis. So we were stuck, and the readings that we had in this case were systemic mastocytosis, which was emerged after the vein disease had subsided, or myelomastocytic leukemia, or simple mast cell proliferation, which is very commonly seen in association with translocation 821. We had missed out on the major criteria definitely by now. The patient was admitted in ICU. It was in remission with mast cell clusters, but after a few days he died because of due to the complications of soft tissue infection of forearm. So probably it has got the thing we derive is probably there were some cutaneous lesions also which were missed in the first place, got infected, and this aggressive pattern of disease also leads us to the conclusion that we were probably dealing with SM. But then before this fifth edition, there are some reservations in classifying the case because D816V was so important. But now the newer WHO classification and the criteria have emerged which say that if you have the mutations, a list of such KIT mutations including variants in codon 417, 501 to 509, 522, 557, and 822. So now this case has an aberrant CD2. The bone marrow aspect had more than 25% cells, but there were large clusters also. So if the biopsy, the aspirate is showing the clusters on biopsy must be there, and then KIT also qualifies because the rarer mutations are now forming a criteria of criteria. So now, the new classification will classify this case as systemic mastocytosis with AHN with bone marrow mastocytosis. Now this is talking about this is one of the cases. This is one of the cases that is going to be displayed in the poster. This is a case of renal NGS with DATA2 deficiency, which is very rare. I wanted to show it, but then okay, you can go back and refer to the posters that we have from our institute. Thank you so much.